How can we eradicate childhood cancer? Please raise your hands if you have any ideas. Anyone who has them are welcome to join our research team, because this is our primary goal on the long term. You might remember from last time that our topic is one of the most challenging topics in the 21st century's pediatric care. So that's why I invite you all to brainstorm with me during this journey. As a pediatrician and a researcher, my aim is to eradicate childhood cancer. This might seem far-fetched, but we are taking every step by step to at least improve overall survival for these children. Our first step is defining the place for targeted therapies in this mission. So, to sum up my two topics, which actually lead to one common goal, is I'm researching the efficacy of targeted therapies, and I'm also figuring out which therapies are the most beneficial for a very difficult to treat tumor, diffuse intrinsic pontine glioma. So, why is this very important nowadays? Did you know that 1 out of 5 children die in cancer if they have a diagnosis in the developed countries, and 4 out of 5 die in developing countries? That's a great number. It's around 90,000 deaths per year. These children die, and it is unacceptable. This places a heavy burden on all the families. $30,000 are spent on each conventional method. At every given moment, 40,000 pediatric patients are treated in the United States. So given at that moment, the cost for the therapy for those children would be $1.2 million. And yet, what do we gain with it? Conventional therapies cause a lot of side effects. 2/3 of the survivors will suffer from these side effects. And here comes the nice part. Pediatric targeted therapies. This could be the intervention point where we could improve overall survival, and with the reduction of conventional treatments, we could possibly reduce side effects as well. So, as you might remember, I compare the additional targeted therapy to conventional methods in this project. What do we mean by targeted therapy, you might ask? This is a very interesting question because it can be defined in a lot of ways, but our definition stands as this. It's a predetermined target that we look for either a genetic or a signaling pathway alteration, and then we give the specified treatment for the patient who has this specific alteration. Conventional treatment, of course, consists of chemotherapy, radiation, and surgery. So we really do believe that these additional treatments will have a therapeutic benefit and increase the overall survival in these children. You can see that this topic is a very complex one in terms of heterogeneity in tumor types, but not only that, also treatment types. From over 20,000 articles, 0.1% can be included in our study. I think that tells you something about the types of researches that are being conducted and the low efficacy of translating results into clinical knowledge. So I would like to present you 3 outcomes associated to quality-adjusted life year increase. These are all survival outcomes. These are very hard clinical endpoints. The first one is the event-free survival, which is measured from the end of treatment until a complication occurs. The second one is disease-free survival, which is measured until relapse. And the third one is the overall survival, which is measured until death. So what can we see in our first data set? The unit of measurement in this case was the odds ratio, which represents the association between the intervention and the outcome, in case our intervention was the additional targeted therapies and the outcome was event-free survival. You can see that this seems to be very homogeneous. There's an explanation behind it. The first study is focusing on CNS tumors, And the second two studies are focusing on pediatric acute myeloid leukemia. So you can see that due to the small number of studies, it seems homogeneous, but with the inclusion of more studies, this will be more heterogeneous. And I also have to add that the event-free survival can be lessened in case of CNS malignancies due to CNS irradiation, because it can cause long-term side effects such as somnolency, even seizures. So all these side effects can occur in both groups. And since we didn't take out the patients from CNS irradiation in the targeted therapy group, we expect that there will be higher events there as well. The second one is the disease-free survival, which shows a favor to additional targeted therapy, as you can see, although not significant, but it is a tendency. With the odds ratio being greater than 1, it shows a positive association. And you can see that in all of the studies, this could be seen. Our hardest outcome is overall survival. And this is my favorite part of the presentation, because this is the data set in which we came up with a significant increase in overall survival, which was our primary goal from the beginning. Of course, we have to see the limitations as well, since we only included a small number of studies that were primarily focusing on leukemic malignancies and not solid tumors. The heterogeneity here, as previously discussed, is similarly low as in the previous ones. So we have to ask ourselves at this stage, what is on the road ahead? What should we involve in this? How should we use this knowledge that's there, but not formed in this very organized matter that is the clinical criteria set for randomized controlled trials? We will include phase 1 and 2 clinical trials focusing on different drugs. We will see the adverse events and the change of overall survival and all the survivals listed before. And even more important than that, we have to include adverse events and we have to compare the two groups. Of course, if you give the same conventional therapy in both of the groups, you will expect at least the same amount of side effects in both groups, but we might see a difference in the cases where they only receive a targeted therapy. And the other favorite part is the basket studies that we could include in this. In those trials, they actually searched for all the patients' targeted alterations, and they gave a therapy according to that. So we are going to go through each alteration and each therapy given, and we will compare it to historical data based on the tumor type. So to summarize this is the first comprehensive analysis in pediatric oncology that includes not only leukemic patients, but solid tumors as well. And it's a comparative study in which we compare conventional and additional targeted therapies. This has never been done before. And we will only include RCTs in the comparative phase. However, we can see that the majority of the articles will focus on hematological diseases, therefore solid tumors will be underrepresented, and the follow-up time is heterogeneous based on studies. And of course, the treatments will be heterogeneous as well, because it will differ from study to study. And what conclusions do we take from this? We need to make more randomized controlled trials. There is no discussion about that. It's not enough. And because we could already see that the use of these drugs are associated with improved survival, we should use them in high-risk patients for sure, but maybe we should also consider giving these drugs to good-risk patients early on. Maybe we can see a drop or a reduce in the conventional treatments. There's actually one article that proved this theory in which they use bevacizumab as an agent. But we need more studies like this. And we assume that the quality-adjusted life years will be greater, but so will be the costs. And what are the implications for research? More basket studies should be done. They should be uniform in design, and we have to draw the world's attention to unify and to show our strength in actually developing these trials together, and we will have our results that we can compare to each other, and that will enhance the knowledge in this field. And what is the implication for practice? I think as clinicians, that's the most important question that we can ask. It will have a 30%, up to 30% increase in overall survivals if we include these patients in these clinical trials. I will be short on this. In
you are out of time.
Oh, 3 sentences, if I may. So in 1962, Neil Armstrong's daughter died in the IPG. 7 years later, he landed on Mars. And since that, we have conquered space. But in the 60 years following her daughter's death, we haven't found a cure for the IPG. Our aim is to find the best of all cure for this disease. And this could be a small step for man, but a great leap for mankind. And I would like to thank you for your attention.
I know that there are a lot of obstacles, so actually right now I'm interested in your own personal opinion that what is the biggest obstacle in the way of targeted therapies being used in the everyday oncological care in broad areas?
Thank you for this very good question. There's a great cost to these therapies, and there's a great cost for finding targeted alterations. The cost of performing a next-generation-based sequencing is around 1 million to 1.5 million forints. And for example, dasatinib, which is a tyrosine kinase inhibitor that was used in one of the patients, costs 700,000 forints per box. So there's a great cost to it. And also, I think we have to change our mindset, because there's a bit of resistance against using these therapies. And even if they do, they use these in compassionate use basis, and we should also change that into randomized controlled trial settings.
Thank you for your presentation. It really looks into the future, and we know that chemotherapy has a really strong role in curing cancer, but biologic therapy and targeted therapy are coming to the fore. And one of your investigated outcomes were quality-adjusted life years. And it is influenced by overall survival, which you have investigated, and so adverse effects has a really great impact on this as well. And what do you think? What are the differences in the in adverse events?
I think to answer this question, we would have to separate the studies in which they give therapies in combination or alone. Because in combination, we will have more adverse events, it's very likely. But with the current state of data extraction, we don't think that this difference would be significant, and we don't think it will have a significant impact on quality-adjusted life years. But in case where targeted therapies could be given alone, there will be a great benefit adverse event-wise, so that it could even improve quality-adjusted life years even more.